Hello, Dr. Emerson.
How do you do?
Good. So where did you go to medical school?
University of Virginia,
And when did you graduate from there?
1967.
When did you start practicing medicine here in Worcester?
I came to Worcester in 1980, and I came from the University of Illinois.
Alright. So what did you end up choosing as your specialty in medical school?
Well, in medical school, you don't really specialize. You take a broad range of subjects. You do have an opportunity in your last year, which has not changed that much, to take electives. I would say that if you want to compare medical school, say back when I was in medical school compared to now, there's more opportunity now to take in your fourth year electives, that is, courses of your choice. And in fact, I think when I was graduating, that was about the time that people started to sometimes go outside their medical school for a experience in another medical school, just to get an idea what medicine was like in another venue. But I got interested in endocrinology when I was in medical school, and I spent at least one summer in an endocrine lab. So I was always interested in sort of how the body is directed, and that's what endocrinology is all about. Now, just sort of to go on a little bit, as I said, I was interested in medical school, and I think my interest remained with me through residency. When I started to pick my endocrinology training, I actually interviewed at a number of places where I was, not only where I trained, but in some other cities to see what area I was most interested in.
So what made you decide to become a doctor? Why did you choose medicine as a field?
It's a good question. I think I would say the time of my life when I was really became interested was actually the 7th grade. I would say my mother encouraged me. So I had the background of encouragement. My mother was not a physician or even a sort of full-time healthcare worker, but she did do things related to health. But in 7th grade, they had a course which was called Anatomy and Physiology. I don't know who came up with the idea of putting this together because it was totally outside the standard curriculum. And I found this very fascinating, that there was actually a system to regulate the body. And the other thing about it was that I did very well in that course. I would say I was a C+ student in grade school, and I got an A in that course. I led the class. Of course, where I was going to school, we had small classes. And that experience stayed with me. But I was always interested in medicine more from a point of view about learning things and maybe even research than necessarily having my own office practice. So I've been in academic medicine all my career, and I think even back then I was sort of heading for that.
Okay. Is there anything else from your residency or internship that you'd like to share? Any other experiences or stories?
Well, I guess just as I said, the 7th grade was a time when I really got interested in medicine, and I think you're interested in something that you do well in. So I was a 2nd-year resident, and one of the things we had to do was to give a talk to the other residents, and we gave it in front of the chief of medicine. And it was supposed to be not just a clinical talk, but it was supposed to be a sort of an in-depth review of a field. And I had just read a review in the American Journal of Medicine about the long-acting thyroid stimulator of Graves' disease. And I knew nothing about this until I read the review, and I was absolutely fascinated by this, because this was the discovery that in patients with the most common cause of hyperthyroidism, they had an antibody circulating in their blood which was stimulating their thyroid and causing their thyroid to be overactive. And in fact, I was so interested in this phenomena that we had a new chief of endocrinology came to University of Penn, where I was training. I was slated to go into a diabetes lab for a few months, actually as part of my second-year residency, and I ran into this new chief of endocrinology, and I was asking him about this interview, and the upshot of that was that after our conversation and some more conversations, instead of going to the diabetes lab, I actually went and worked in this Dr. Udiger's lab. So I took a somewhat different residency in that the second half, the last 6 months of my residency, rather than doing a traditional medicine, I actually worked in an endocrinology lab. And in a sense, I started my fellowship a half a year earlier. And I have stayed interested in the thyroid for the rest of my career.
So, after your residency, did you go on to the University of Illinois?
Yeah, my first I started out in 1967. I went to the University of Penn. I did my residency there. And then, as I said, I was going to look for a fellowship in endocrinology at other institutions to sort of broaden my experience, and ended up staying at the University of Penn when we had the new chief who came from Washington University in St. Louis. So I did a year of fellowship, and this was the time of the Vietnam War, and every physician essentially, every male physician essentially had to serve in the armed services. The only exception was if you could find something in the public health service. As it turned out, there was what they called the Berry Plan in those days, and this allowed me, instead of joining the Army immediately after my internship, it was a lottery system, and it allowed you to finish a residency. So after I won that lottery, I had about a 30% chance of winning that lottery, and I deferred my going into the service until I'd finished my internal medicine residency and a year of endocrinology. And I went to the Fort Gordon in Augusta, Georgia for 2 years, where I was the endocrinologist for 2 years at this Army Medical Center. Then I went back and did another year, and then went into the University of Illinois. But to back up a second, just in terms of, this is supposed to be about recollections, as far as I know, from the Second World War till around 1972 or 73, there was the so-called doctor draft, which I was taking part of. I said every male physician had to serve in the armed services pretty much. In those days, most of the physicians were men. Just to go back to my medical school class, we had one woman in my medical school class. And as you know now, it's about 50-50. In some medical schools, there's more women than men. The class just before me had 3 women. Really, I don't think the number of women going into medical school, I would have to really guess at when that went up. Another point, you asked me why I got interested in medicine. When I was very young, I had a lot of trouble with asthma. I was in the hospital a lot. Interestingly enough, my doctor was Bethel Fleming, and she was a woman who had gone to the Women's Medical College of Pennsylvania, which is now has a different name. So I was exposed from a very early age, actually, to women in medicine by having as my primary care doctor, Dr. Fleming.
So what do you think made you keep being a doctor once you had started practicing? What did you really like about your practice?
Well, I think you'll notice probably that I did not have a typical medical practice. Although it's become more typical, I would say, in the last 10 years. But when I went to the University of Illinois in 1974, I went to that institution because they promised to give me seed money to do research. And so I had a certain amount of protected time, but the subject matter was what interested me. I believe, I worked in nuclear medicine at the time also. In fact, in those days, nuclear medicine was just beginning. One of the interesting things about nuclear medicine is it really evolved as a specialty during my training period. I can recall when I was at Penn, when they had their first nuclear medicine physician, and this person, I believe, could have been a pathologist. I can't remember. But in those days, what was happening is that physicians were switching to nuclear medicine from other specialties. And one of the things about one of the early nuclear medicine procedures was the thyroid scan. So that was right in my area. And so as a result of this, a number of the chairmen or chiefs of endocrine divisions in the United States actually were endocrinologists. And where I went to at the University of Illinois, we had a program both at the hospital of University of Illinois Hospital and also the VA Westside Hospital. And I did nuclear medicine as well. I actually was eligible to be board certified in nuclear medicine at the time. But I think even though I liked laboratory research, I liked sitting down with data and interpreting it, I also enjoyed my contact with patients. And nuclear medicine was not something that interested me that much because there didn't seem to be much patient contact. But I think what I was interested in not only was putting together data, but also writing and publishing, formulating a hypothesis, and actually trying to write it up in a way which was reasonably well written and understandable.
Could you describe a typical day when you first started practicing in Worcester in terms of your hours, how often you were at the hospital or at your office, and your rounds at the hospital and how many patients you would see?
Well, when I started at the University of Massachusetts, I actually had 1/2 day of clinic a week, Tuesday morning. So you might say, what was I doing the rest of the time?
Yeah.
What I was doing the rest of the time, some of the time I was on the consult service. There was a certain number of meetings and conferences to attend, but the rest of the time I was doing research. And I was doing both clinical research and more basic research. So I was planning experiments. I was trying to collate the data of experiments that we got. I was sitting down and writing papers with fellows. So we had to write up our research, not only for final publication, but also to present at meetings. And generally speaking, I would say I would get to the hospital at about 8 in the morning, and I'd leave sometime between 6 and 7. I would say that unlike some of my colleagues who probably worked longer hours, I got out near to 6. As far as the patient practice went, some cases I saw the patients myself. In other cases, there were residents who saw the patient first. I would, if you want to sort of contrast my experience, in those days, I would say more of my patients tended to be seen by residents or fellows, and then I saw them with them. Now we've evolved into a system where I think the attending physician really does almost all of the work, and the residents and fellows tend to be somewhat on the sidelines. The other change, obviously, or not obviously, but is that I'm seeing a lot more patients. I'm now doing about 5 times as much patient care as I was doing before. Unlike my early days, I'm now going to several off-site clinics. I go to Gardner twice a month, and I go to Westfield once a month. And at one time, I was going down to Connecticut once a month and to Athol once a month. So all of this, I believe the reimbursement rate has probably dropped, so you have to see more patients to maintain the same income. It's all been driven by, you know, the economics of medicine.
Which we will get to soon, but before that, could you tell me if you ever made any house calls?
I did not.
Okay.
My only exposure to the closest thing to that was when I was a resident at Penn. I went to a very tiny clinic which was right in a neighborhood, and the neighbors, so to speak, would come to that. I made a couple house calls when I was actually in the Army, and possibly even early on in connection with research projects, where I go see somebody and I draw the blood or something like that. Just while I'm on that subject, drawing blood, when I was a fellow in endocrinology, we were the first place in the United States, along with 2 other institutions, to do a measurement called the TSH assay, which is a thyroid function test. It is now the most popular by far thyroid function test. But at that time, we were one of the few places that could do that. As a result, we drew blood on just about everybody we saw. We could do this test. And one of the things I sort of muse about is that in those days, we could never imagine that one day we would be wearing gloves and be petrified about drawing blood because of the risks of AIDS. If anybody had told me back then, you know, you could get a lethal disease if you're not careful from this blood, I would not have believed it. We had thousands of blood samples saved. We also, so that was one thing. The other thing, which is unrelated, but again about this TSH assay, which shows you how medicine evolves. At the time I was a fellow, I studied patients taking lithium, which is an agent for manic depression. And we found out that lithium affects the thyroid, tends to make the thyroid underactive. And I recall that when we first submitted that for publication to one of the major internal medicine journals, it was rejected because they said you're using a test which is too much like a research test, and we're not interested in that. We want something more clinical. Now, of course, every clinician is familiar with the TSH test. So everything is a matter of perception in medicine.
What do you think it's been like for your family to have a physician in the household?
Well, I think it's hard to say. I think overall, I would say that I'm probably somewhat uptight. In other words, they have somebody living in the house that's a stickler for certain detail, and maybe not as laid back. I have not taken more than the longest vacation I've taken, I believe, and since I graduated from medical school, is probably 2 weeks at the very most, and most time. So they've kind of lived with somebody who's a little bit uptight. Always, you know, in medicine, we always think about the differential diagnosis and the possibilities, and also everything that comes up around the home is, you know, it's 50% chance of this and 20% chance of that or something else. So physicians are obsessive compulsive. You become obsessive compulsive because you worry about somebody getting into trouble because you forgot to call them or you forgot to check a lab test. And you also have the sort of doctrine of individual responsibility, which I think patients find it a little bit difficult to to understand. And that is, they wonder why, when they see a physician, why the physician has to ask them the same questions that everybody else asks. And it's because a physician feels that the buck stops there, that you know, you can only go so far in accepting other people's diagnosis. You have to make it on your own. You have to check the facts on your own. And that's really foreign to most households and all. So it kind of makes you a pain sometimes to be around. But overall, I would say, I think my, having sounded a little bit negative here, I think that my overall influence on with my family and all has been a positive one. You know, because they also know that, you know, I'm very interested in this, and they know what it's like to be interested in things. However, we've done a lot of things that don't relate to medicine, and I have interests that don't relate to medicine either. So.
And you saw your family often, or didn't get too much in the way?
I actually, I think, saw my family more than most doctors because, as I told you, I was doing, you know, 1/2 day of clinic. I didn't want to stay at the medical center too late at night. I was not, you know, one to be there and gone all the time. And, I mean, I go to meetings, but I don't want to be at meetings all the time. And I don't do a lot in terms of committees and things like that, which take you away from your family. So I think my family got to see me, maybe not for long periods, but they got to see me.
Did you ever have any vacations?
Yes, we did. We've been going to Florida for a number of years. You know, and usually the family goes along. We go to a place called Sanibel Island, which is one of our favorite places. When the kids were younger, when we lived in here, when we first came, and we went to the beach in Delaware. And so my children have fond memories, I think, of mainly our beach trips. We've gone to the Grand Canyon and done a few other things, but we haven't taken as many vacations maybe as some people have.
Okay. Well, back to your practice now. What were some of the most typical illnesses that you dealt with when you started practicing medicine?
I'm dealing pretty much with the same illnesses now that I dealt with then. Unlike maybe some practices where there's been a big change, the change that I have seen is that we have much better techniques than we had back then. The major sort of techniques that have evolved in my lifetime, the imaging techniques, were not present. When I was a medical student and a resident, CPCs, in a sense, were much more popular because one had to come up with a diagnosis based on a physical exam and laboratory features, you didn't have the ability to image nearly as well. I can recall once when I was attending and the first time that we got a CAT scan showing a tumor in the back of the brain, which really had been a difficult diagnostic thing to do before that. We have methods to measure hormones that are much better now than when I was in medical school. Believe it or not, when I was in medical school, we could not measure thyroid hormone in blood. And those techniques evolved while I was in medical school and as a resident. They've become more sensitive, they've become more specific. The other major another one is the ability now to determine molecular structure. In the early eras, you had to purify things by very painful protein purification. Now you get the DNA structure and you can get the protein structure from that, and it's all become much easier. The first releasing hormone, the hormone from the brain that directs the pituitary, was discovered right when I finished, shortly after I finished medical school. That took literally thousands of brains and giant columns that ran 2 stories high to do the purifications for those hormones. So we now have techniques, we have tremendous imaging techniques also. I mentioned, when I said imaging, I don't mean now the CAT scans and all, but we can image proteins in tissues and in cells. Well, I think I had said that really that I'm not really dealing with any diseases or illnesses now that are different. There are some exceptions for that. We're still dealing with hypothyroidism as our major disease and thyrotoxicosis as our major disease. I think the difference is that with the development of these techniques, we can recognize very mild forms of these disorders. And so now we are really much more knowledgeable about where exactly the degree of disorder that a patient has, the degree of disturbance. There is one new syndrome which was not well recognized in my time, and that's silent thyroiditis. And that's transient thyrotoxicosis in people who are otherwise hypothyroid, or at least disdain to become hypothyroid. The other area we do a lot with is thyroid cancer, and the techniques for detecting, for managing thyroid cancer have evolved. We are able to pick up milder forms of thyroid cancer. We're able to more precisely diagnose recurrences. And so we have a broader picture of thyroid cancer. So that the other area is within the thyroid cancer area, there is the ability now to actually use molecular probes to diagnose medullary thyroid cancer and find out who is going to be at risk of that. So the other impact which is developing and has been developed is the genetic analysis, which is going to allow us to more precisely define people's risks of disease. We still have a long way to go. A physician nowadays doesn't really have good access to a molecular biology lab that can do the probes to determine what is, what particular genetic disorder you're dealing with. But for the more common ones, that is evolving. And I think people are certainly looking down the road and saying that the problem in the future is going to be that we're going to know too much about our patients. And they're going to know too much about themselves, and they're going to have difficulty living with that, because if they know they have a certain risk or something.
What disease would you say was the hardest for you to treat?
Well, I think that thyrotoxicosis was somewhat difficult. I think it's become easier for me to treat. Thyroid cancer is still difficult to treat. The thing I would have to say that the thing about endocrinology is, even though I've mentioned some major diseases that you deal with, you are still running into every 20th patient is going to have something very unusual. There are literally hundreds of very rare endocrine disorders which you can spend a lifetime in practice and only see once or twice. But you've got to be ready to treat that. And that's the challenge, to recognize that when the patient presents and now try and now treat that rationally. So endocrinology, you know, even though like a lot of other fields there's a so-called bread and butter type of things, you are challenged. And like snowflakes, every patient is different. And I think that's really the essence of medicine. It's not only recognizing a particular disease, but recognizing how a patient fits in, how that disease fits into their lifestyle, and also how maybe their lifestyle or what they did influenced the presentation. Give you an example, just came to mind, is a patient I saw a few years ago who presented with hypercalcemia, high serum calcium level, and the patient, only by taking a careful history, it turned out that he'd been camping in Florida for 3 weeks and had been out in the sun most of the time. And that gave the clue that his problem may have been triggered by excess vitamin D, which is known to cause hypercalcemia in people with granulomatous diseases. So he actually had sarcoidosis, and his calcium level would probably have been fine had he not been exposed to all the sunlight, which then the granulomas of sarcoidosis converted that vitamin D into the very active 125D and precipitated hypercalcemia. The history, you know, is very important whenever you're dealing with a patient.
Yeah. Well, I believe you already discussed breakthroughs in disease treatment and technology and disease prevention, but could you name a single most important breakthrough in disease treatment during the course of your career?
I think you're putting me on the spot here.
I'm sure there have been many.
There have been many, but in terms of endocrinology, probably actually one area which is very important, which we had really not much we could do for, was growth hormone. In the old days, you had to get growth hormone from cadavers. So in recombinant technology, which has allowed us to synthesize proteins, has been a tremendous advance. And growth hormone deficiency is no longer a sentence for being markedly short in a patient with growth hormone deficiency. Certainly, insulin being synthesized by recombinant TSH has helped a situation which could have become very critical, because my understanding is that the reason that recombinant insulin was developed was that they projected that they would run out of insulin supplies, which were normally prepared from cattle and beef, unless they found a new source. I'm sure there are others that I haven't touched on.
Okay. How about disease prevention?
Well, I think one big area of disease prevention, not in Worcester County, but in the world, is the recognition that iodine deficiency is, by some estimates, the world's major cause of let's see, or one of the largest causes of mental retardation. There were large areas of the globe, and there still are, where there's iodine deficiency, and as a result of that, cretinism. With iodine supplementation, that has helped the situation. Here in the United States, screening for congenital hypothyroidism has made cretinism from congenital hypothyroidism a thing of the past, by and large. When I was in medical school and in my early years of practice, babies were still being born and going through the first few years of life without their hypothyroidism being diagnosed. Interestingly enough, the first program for screening children for infants for congenital hypothyroidism was in Canada, and that program was started when they wanted to detect a disorder that occurred in about 1 in every 100,000 infants. One of the people who was from Quebec did a fellowship in California with an outstanding thyroid group and came back and introduced the idea of screening for congenital hypothyroidism to the Quebec neonatal screening program. And there they found that the incidence of congenital hypothyroidism was about 1 in 4 to 5,000. So he was able to introduce a technique which would pick up for every one patient with this rare disorder that the program was developed for. Now they were able to pick up approximately 20 infants who would have had some degree of mental retardation, in some cases very severe mental retardation. So that has managed to really, if you will, cure one very important cause of morbidity. And of course the lifetime cost to society of a severely retarded person is quite high because of all the care they need.
Could you briefly describe attitudes towards smoking and cancer throughout your career?
I would say that's a very interesting question. And I don't know, I know you were talking with a number of physicians about this, so it'd be interesting to see how they answer that question. But I suspect that a number of the physicians you've talked to have pointed out that when they went to a medical staff meeting, when they were in medical school or early years, that there were a lot of smokers. And I can recall that, in fact, that was the case for endocrinology. There weren't a lot of smokers. Physicians were the problem, but there were some very prominent people who smoked, including a very prominent thyroidologist who I recall American Thyroid Association, when at the end of during one of the meetings, a person who should be given a lot of credit, J.J. DiStefano, as a matter of fact, got up, and he wasn't an M.D., and said, we need to ban smoking from our meetings. And after some debate, and I have to say a certain amount of embarrassment on the part of the audience, because this particular person was almost prominent and they realized it would affect him, there was an overwhelming vote to ban smoking. And so even back then, there was certainly a reluctance to raise the question, but once the question was brought out in the open, there was no question that something needed to be done. I would say that I am continually impressed as I see patients of the devastation that smoking renders to their lives. Everyone, particularly patients with diabetes, and despite all the controversy, all the publicity about smoking, it is still a major problem. So I am aware of it. I was always I'm more viscerally aware of it now because I've seen the problems that smoking has given in terms of heart attacks, loss of limb, etc.
Okay, well, obviously there's been a lot of new technology since you started practicing medicine, but is there any specific technology that you see doctors particularly taking for granted now that you didn't have during your career or when you started?
Well, the obvious ones I've sort of talked about, the imaging ones, but I think the ones that are a little more subtle are things like the IV pumps that control the rate of the delivery of IVs, the breathing machines that are controlling. All of these things have been automated. In my day, when I was a house officer, we had to be continually checking the IVs and the nurses to make sure they were going in at the right rate. And so there was a lot of scut work involved with taking care of very ill patients. And I think that's really, in some respects, in terms of affecting the day-to-day life of physicians, that's probably important. Now, I might say the other thing is that the ancillary support, despite all the complaints that people have now that they about ancillary support, that has improved. When I was a medical student, I drew the bloods on my patients, and I continued to do that. I did CBCs. In fact, one of the problems we have now, I believe, is that physicians are not as savvy about laboratory procedures as they should be. And they are dealing, so much with, it's almost like a pilot flying a plane in a totally artificial environment.
What technology is still frequently used today that was in use when you went to medical school?
Drawing blood and giving injections.
Okay.
Yeah, I mean, we still use x-rays. Basically, the plain film has not changed that much. The stethoscope is the same.
Okay.
Those technologies have not changed. But disposables have changed tremendously. I mean, in my day, you didn't have all these disposable items that you have now.
Did you always have access to the new technology in your field?
I had more access than many practitioners, I should say, in the sense that I was always at a university medical center. So certainly, just looking back, and even now, when I had access to the TSH assay throughout my career. Many hospitals did not get that technology for another 5 to 10 years. Similarly with other thyroid function tests, we had access to some of the better nuclear medicine scanning procedures for the thyroid. Although the one area where bureaucracy, if you will, intervened was that there was what they call you had to show necessity. And I can remember at one time in Worcester where in order for somebody to have a CT scan of the brain, they had to go to one hospital, and if it was of the abdomen, it was another hospital. So they tried to put this technology in different sites, and the result was that that would often result in limitation to technology. The same thing occurred when MRI started. Now I think both of these technologies are widely available, and we really don't have too many examples of highly restricted technology.
Could you comment on how the drugs of your field have changed over the years? What drugs you used then and what you would use now?
Actually, the drugs that are used to treat thyrotoxicosis, some of the fundamental drugs have not changed that much. The thyroid hormone preparations have gotten better. There's been more recognition that there can be defective stocks. We've gotten away almost completely from using thyroid hormone from pig or cattle glands. It's now all synthetic. Having said that, however, one of the major areas that is different is the web. And now there's a lot of medical information given on the web, and some of these tout so-called natural treatments, and in some cases they're giving thyroid hormone made from cattle thyroids and things like that. So it's almost a step backward. To digress here, if a patient tells me about something that they saw on the web, rather than trying to have a discussion about this, at that time I ask them to print out the web information and bring it in so we can discuss it. And I also, when they bring it in, I also try and do an online search right in front of with the patient of the medical literature. And so I will tell them what are the sources that we use as physicians, and I try and explain the concept of a peer-reviewed paper to them. If they're discussing a certain thing, I will actually try and do a literature search right there with the patient on this topic. The other day I saw a woman whose problem was that she was sweating too much, and she thought, well, I must have a problem with my glands. So she thought, well, if I have a problem with my glands, it's an endocrine problem, so I better see an endocrinologist. And every once in a while we do get referrals for patients with increased sweating. It's not really, in most cases, an endocrine problem. And she asked me about this technique, and I said, well, I don't know too much about it. Let's see, and she'd actually brought this stuff from the web, and I said, well, let's see what's available. So I went to the National Library of Medicine website and was actually able to pull up a number of articles on this technique, which I was not familiar with. So it works both ways. I'm learning from my patients, very literally in that situation.
So do you think the fact that your patients are gaining information of their own and trying to tell you things has to do with how the public perception of doctors has generally gone down over the years since you started practicing?
I don't think so. I think that people are more educated nowadays in certain respects. There's so much information available, and it's available through a visual media, and there is also the people can get the information. I mean, basically, as I understand the political process in this country, if you went back before the era of television, people learned what they knew was what they read in the newspapers. And they had limited knowledge. They had to depend on the integrity of the press and all. Now they can go out and get the information. And so I think that's what people are doing. They're going out and getting the information. I don't think they have any less trust of their physician. Maybe they have a more realistic view of what a physician is able to do, and than in the past where there might been more sort of blind trust. But I think clearly it's important that the patient be somewhat aware of where it is, what it is that you base your recommendations on. It's not simply pennies from heaven or something that's divine inspiration. That these are based on the same kind of thought processes that they use every day. Well, you asked me about managed care and how that has changed medicine in my lifetime. I think clearly that seems to be the topic of the day, if not the last 5 to 10 years, that the whole practice of medicine has changed tremendously. Um, Back when I was a medical student, one could simply go to the hospital with a problem and you were admitted to work up the problem. So oftentimes people sometimes didn't really have serious problems, but they were tired, they felt sick, and they wanted to check themselves in the hospital. That has certainly changed. Nowadays, you have to have almost meet certain criteria in order to get into the hospital, and you have to meet criteria to stay in the hospital. And all of that is driven by managed care, not just from companies, managed care companies, but by edicts from the government. This, of course, has put a certain amount of stress on the delivery of medicine, and it has meant that in some cases doctors really get to know their patients less well. Patients, there's a tendency for patients to be treated more mechanically because you're trying to meet certain benchmarks in terms of what the patient's illness is, so you can document this on the chart, and you can document the reason for them being in the hospital, the reason for why they can't leave or why they can leave. So the other area is that everything you have to spend so much time documenting that you really don't have enough time to sit with the patient and actually practice medicine. And this is almost going to sound like a cliche. But here in front of me are what is known as the ICD-9 codes for the symptoms of hypothyroidism. And physicians are expected to look up these codes. Here there is about 20 different signs and symptoms that you can see with hypothyroidism. Now, it doesn't seem to make a lot of sense that you would spend your interview time with the patient trying to figure out which ones of these things they have and which you should put down on your bill. The other thing, of course, is that we have become a society where certain people have access to fairly good care and other people do not have access to good care. In general, I would say that the people that have access to good care are people who belong to large groups that can afford to negotiate for to be included in either an HMO or insurance program, and the very poverty-stricken members of our society who fall under certain programs. The people that have the hardest time are people who are self-employed or who are not in a small business when they cannot have the leverage of belonging to a large group. Certainly everybody who has sons and daughters who are getting out of college recognize this very fast, that all of a sudden now they are going to have to find a job where they get decent health benefits. Well, there simply aren't enough of those jobs available. And so they are, in a sense, to use an expression, going bare in that they are not really covered by insurance. As far as access to health care, obviously there are disparities. I think I'm bothered by that as a physician. I'm also bothered by some people who seem to take advantage of the system when they could pay a certain amount of money and simply have the mentality that everything is owed to them. And I don't think that's a healthy system either. This is an incredibly complex topic, and it's going to require continual dialogue between physicians, between providers, and between patients. And I think every all of these groups can sometimes be off base a little bit. Now, we go on to another question that you have here, and that is, how much did it cost for you to go to medical school? And do you think the increased costs today influence the choices of young doctors after graduation? Well, medical school has always been a somewhat expensive proposition, but I think it's probably gotten worse. I was very fortunate in that my medical school, I actually had a scholarship to go to medical school, and I paid in-state tuitions. And so as a result, when I was in medical school, financial considerations played almost no role in my choice of what specialty I was going to go into. But for a lot of people who end up with debts of $100,000 or more very easily, it is clearly going to have to influence their choice of a specialty. And I see this very much in endocrinology because, in general, graduates of U.S. medical schools do not tend to go into endocrinology. It is not viewed as an area where one can make a lot of money. Endocrinology is one of those specialties where there are very few procedures. Probably amongst all of the internal medicine subspecialties, endocrinology has the least number of billable procedures. And these are where the big bucks, so to speak, are made. So as a result, if you look at our fellowship program, and I think we've gone through quite a bit of this interview, but I should mention that I am a professor at the University of Massachusetts Medical Center. I'm heavily involved in education of fellows. Most of our fellows are from abroad, and they don't have the same cost considerations. Moving on.
Yeah, how do you think malpractice insurance has changed over the years?
Malpractice insurance has become a huge problem. I've been relatively sheltered from that because I'm part of a big group that's self-insured. But for the individual practitioner, it's become an absolute nightmare. And it affects me indirectly because I realize that if I ever wanted to go out and practice on my own, perhaps after I retire from full-time practice, have a small practice on my own, perhaps not in Worcester, in some other area, I would have to worry about getting malpractice insurance. This is clearly a problem that needs to be addressed in order to reduce the cost of medical care. But while I'm on that subject, I think that one of the things that's not recognized when we talk about costs and medical care and all is that the medical health industry has become an enormous part of our U.S. economy. And anything we do to cut costs inevitably affects employment in this area, and so it has repercussions that aren't necessarily straightforward. Now, I don't put malpractice in that area, the cost of malpractice. I think that is a waste, that things could be done. There does need to be, obviously there needs to be accountability, but the accountability should be appropriate and not inappropriate. So when you use the counting methods to figure out what a damage should cause, and rightfully so, you should use accounting methods, the similar accounting methods, if you save somebody's life. Now, obviously, when you treat somebody with hypothyroidism, you don't charge them $100,000 for making their life so much better for the rest of their life. So, but that's a digression. Any other questions before I go on to women's health? Changes in women's health. The specialty I'm in, actually most of the patients are women. I don't see major changes in women's health. I think there is definitely more emphasis on targeted research grants for women's health area. That's not necessarily a good thing. I think that it is important to make sure that our research, our clinical research, covers everything. but we have to be careful of targeting research rather than allowing scientists, investigators to find truth where it is. Now, you asked me, I guess we go on Worcester demographics. Obviously, Worcester is becoming more heterogeneous in terms of its people. We notice in the training area that we're training a lot more foreign physicians, and we're seeing people from countries that we didn't see 5 or 10 years ago, such as from Africa. To a certain extent, a few years ago, it was from Russia and from the Balkans that we're seeing. We're moving through this fast. You asked me why did you choose Worcester and what do you like and dislike, and I have to say, frankly, I came here because of the opportunity to do research at the medical school. Worcester, I think, is a wonderful place. It combines an environment, a unique environment, in that you can have rural medicine here, you can have suburban medicine, and you can have urban medicine. You can be in Boston or Providence or downtown Worcester within minutes in this area. On the other hand, you can be at very small communities or in very sophisticated suburban areas. So I think I'm at the end of my series of questions that you just gave me.
Lastly, Dr. Emerson, what advice do you have for young doctors just starting out in their practice?
I would give them, I hope that they would get their advice before they start out in their practice, and that's in their training years and when they are contemplating what to do. But I would say, think about what kind of lifestyle you want, and then try and tailor your practice to that. The other thing is realize that medicine has its rewards and it's also the price you pay. That, in fact, the enjoyment that you get out of medicine can be very subtle at times. But that you will, if you're interested in the area and you're interested in people, medicine can be a very rewarding career.
Okay, one last thing. How have you kept up with the changes in medicine, obviously, which there are many of, in terms of education? How do you keep up to date?
Well, we have a certain amount of conferences I go to. I think the web has been helpful in terms of being able to access the medical literature. That's very helpful. When I can recall when I used to type out in